And last presentation, this session, Pavel Atanasov. Please, how we can make embolization vein from inside.
Just for the audience and to make some discussion until the presentation, do you make a Doppler of the veins on every peripheral patient, not only the arterial? Do you check the veins? How many of the audience check the veins if the patient is with the peripheral arterial disease? Does any experience Doppler?
Check the vein, see if it's fit for bypass, but not for insufficiency.
You check the vein just for the bypass. And another question, I mean, probably the surgeons will not agree with me, but why does the prosthesis grafts last less than the vein grafts? As a discussion. Maybe one of the discussion is because we take out the vein insufficiency while we are stripping the vein for the bypassing. So the prosthesis graft has in the system active vena saphena magna, but in a vena graft we take out the vena saphena magna and there is no incompetence. Maybe. Pavel, I think.
We can continue with Dr. Pavel.
Hello to everyone, dear colleague, dear moderators. I'm Dr. Atanasov and vascular surgeon. For me, it's an honor to be here. Next few minutes, we're talking about varicocele. As we all know, the varicocele is abnormal enlargement of the group of vein in the scrotum, affect around 15 to 20% of the all mankind. The veins are similar to varicose vein found in the legs. Impaired venous functions in the veins can cause swelling of the vessels. A varicocele occurs when blood pools in the vein rather than the circulation efficiency out of the scrotum. The veins transport oxygen-depleted blood from the testicles. Varicocele usually form during puberty and develop over time. Varicocele may cause poor development of testicle, low sperm production, and infertility in the patient. Affects most common the left testicles because the vein of the testicle veins follow slightly different paths than the right one. Most often have no symptoms. The most common symptoms are discomfort or pain. It's more likely when the patient is standing or later on the day, and the patient relief when the patient is laying down. The patient said that they had a slowly growing formation in the scrotum, and they saw that there is difference between the testicle size. The affected most common left testicles is significantly smaller than the healthy one, and the infertility is the most worst complication of the disease. As I said, the patient have no symptoms. We got classification of varicocele, the first, the second, and the third grade. Of course, depend on how dilated of the varicose vein on the scrotum are. The first and the second grade, the varicose vein are really small. This is really hard to feel, to see, and the ultrasound examination is required for right diagnosis. When the patient has a third degree, the veins are visible. The patient feel it with the touching, and most often has no symptoms. Treatment, we have a few options for treatment. The open surgery, the procedure is called varicocelectomy. It's the most common surgical procedure. We use inguinal, suprainguinal approach for ligation of the target vessel and retroperitoneal approach for height ligation of target vessel. The laparoscopic and microsurgical varicocelectomy is another choice for treatment. during these procedures, we use really small skin cuts for approach to the vein. And varicocele embolization is procedure that close of blood flow to the affected vein, causing the varicocele to shrink and die off. And we all know that there's another choice. We use a sandwich technique to make a selective embolization of target testicle varicose vein using chemically induced thrombosation of the vessels. In Bulgaria, we may have can use polidocanol and etoxiclerol. I've got several cases, but I decided to show you one of them, and I hope you find it interesting. We're talking about a young male, 20 years old, with third degree of varicocele of the left testicle. The patient already have made semen analysis, which semen analysis was performed, which show a decrease of abnormality in the sperm count, mortality, the morphology, and fertility issues. Our first choice after examination, of course, was the endovascular treatment. We use a typical puncture of the right internal jugular vein. We use a fine French introducer, then 0.35 guide wire, and multi-purpose anglet guiding catheter, because it's more easy to navigate. Of course, the procedure is safe, and there are some risks, like allergic reaction during the procedure when we use the contrast material, excess bleeding, migration of the coil, postoperative risk of infections, lower back pain, inflammation of the scrotum, and the vein nausea. The next slide, I will show you the procedure. The first picture on the left, you see the selective cannulation on the left renal vein. You see with the red arrow the confluence between the testicular vein and the renal vein. You see that's really small and really short, tiny. You see the bifurcation that we know was really hard to make selective catheterization because we've got a conglomerate of varicose vein. But after several attempts, we made it. The picture on the right, you see the selective cannulation of the gonadal vein, left gonadal vein. This slide shows the conglomerate of the varicose testicular veins. You see the tortuosity of the veins. There are some kinks, deviation. It was really hard to make, to navigate and to make selective cannulation, but with them. Видеото може да го пуснем? Дайте един слайд назад и после пак. Както да е. Добре. Sorry about the problem, but I want to show the video during the procedure. The first video showing the first selective cannulation on the medial testicular varicose chain. The another one, the middle one, with the U-shaped form. Следващия слайд може? Okay, when we're done with the selective catheterization of the gonadal vein, we put the first coil. We use a 20 centimeters, 8 millimeters wide nesting embolization coil. As we all know that the most important thing is sizing. Sizing of the coil depends on the size of the vessel that prevent the migration of the coil. This is the first coil. We see after that there's no contrast distally. The vein is fully occluded. I guess there's another video, but we can see it. Следващия слайд. Okay. After a few minutes, this showed the second coil, most proximally. We see it, and with the red arrows I showed a few minutes after embolization, we see the fresh blood clots forming. And the next picture show on the right the fully occluded of the varicose vein. Следващия слайд. Sorry about that. Следващия. And this is a final selective venography to see that the renal vein is all, and to be sure that the procedure performed safely. We don't have a iatrogenic lesion, we don't have a rupture or thrombosis. Следващия слайд. Okay, patient, the procedure was safe. I already said that, and painless. The patient with no compliance, with calm abdomen, without peritoneal irritation and restoring passage. The patient was discharged to a second post-operative day. We prescribed, of course, the venotonic drugs, make a follow-up with color-coded Doppler sonography at the first 14 to 20 months, and after 6 months, a semen analysis showed the good result after procedure. Our conclusions, as I already said, the procedure is safe and painless, but that depends on the skills, the experience of the surgeon and the team. Vascular embolization is a minimally invasive procedure that requires no general anesthesia. We use only local anesthesia with no scarring, reduced risk of infection, quickly recovery time compared to the open surgery, and success rate around 90%, which is similar to surgical technique. And thank you for your attention.
Thank you for the presentation. Questions? Do you have patient problem with spermatogenesis after procedure or with erectile function?
No.
No.
Until now,
It's
no.
safe.
We got 8 patients in the last 1 year. It's all fine. We've got
After embolization by coil, do you must to have any medication?
only venotonics without painkillers.
Only
Only,
painkillers?
yes.
Yeah, thank you. If you not more.
I do have one more question.
Yes.
Do you have any experience with female embolization of female?
Yes. I already got 4 patients.
Okay.
Yeah. But in this case, with the female, we use a sandwich technique. We use a coil and chemic induced thrombosis, propranolol and toxiclerol.
Thank you. It's all for this session. Thank you for your attention. Now we have a short coffee break. After that, about session.